So it's now my great pleasure to introduce our keynote speaker this morning, Dr. Emma Gordon. She's Director of the ADR UK Strategic Hub and Director of ADR England. She is responsible for setting the strategic direction for the program, leading on the coordination of the partnerships and engagements with senior stakeholders to improve access and analysis of administrative data to improve. The floor is all yours.
Yeah, lovely to be here, and I'm coming at this from a whole different perspective, but health data is incredibly important to what we do right across ADR UK, and I'll give some fantastic examples of how we've been able to open up access to that for public good research. So just before I start, the ADR UK partnership is UK-wide, and it aims to have government civil servants working with academics both to open up access to the data, link it, make it available for wider research use, and all of the data linkage projects we fund end up with data being made available for wider research use in all 4 UK nations. And then we also fund communications and engagement, public engagement, research using these new flagship data sets, and it's now a massive operation, which I'll say a little bit more about at the end. So when I talk about administrative data, it's literally any form of data that is collected off a government system or service that we're interested in. So the types of data that we've linked to date have included education records, Ministry of Justice courts and prison service records, health records, employment and earnings, and census responses. And I work at the Economic Social Research Council, not the Medical Research Council. That's quite important, because when it comes to health records, as a programme, we're not interested in just linking health data or making health data available on its own. It's that linkage across to other forms of data. And that's where you get the really interesting insights about people's lived experience, about their background, about other things that might be impacting on their health or other aspects of their lives that might mean treating their health might be more complex. And if I explain briefly why this is so difficult in the UK, it's like a microcosm of the world. The UK is made up of 4 nations, and we have devolved government, which is a brilliant thing. It also makes it much more complicated to link data, because with things like education and health data, which are entirely devolved, you have 4 different education systems, 4 different health systems, all working to each individual government's priorities, not some central organised thing. So the data is got things like HMRC that are UK-wide, more or less, and justice and benefits data that are somewhere in between. So it's really, really complex. That's why we have one trusted research environment in each of the 4 UK nations, and the Wales one is run by Swansea, the Sale Data Bank, and it's really important that we have and forms of research that we fund, so economics, criminology, education research, because we absolutely recognise right from the very start of our programme that although it's absolutely lawful for us to be making this data available to researchers in de-identified ways and linking it and everything, we have to work really hard to maintain that public trust and the social license to use this data, because we are one bad story away from this all being shut down. And we want to talk about the positive use of data, and really good to see colleagues from Use My Data over there in the corner, because it's a really, really important charity who are promoting the public good that can be done with this data. We get a lot of scare stories, but you know, you need the power of the good stories to kind of counterbalance those. And I'm not pretending there aren't risks, of course there's risks, but you know, this is our insurance policy. This is how we make sure that we demonstrate to parliamentarians, to the public, to researchers, that we're using this data responsibly. And so a really good example of how we do this is if we're doing research on young people, vulnerable young people, we involve them in the research. And this is an example of some fantastic work that was done with our Northern Ireland partners and the voices of young people in care, and getting them involved in the co-production of not just the research project, but also how you talk about it in the public domain. And we've done this within our team as well. So, you know, getting young people involved in, you know, kind of making sense in their own language of the types of research outputs that we produce. Because at the end of the day, if research about people doesn't speak to them and isn't understandable to them, we're not doing our job. And so, yeah, the vision that's now being realised, and was set up in 2018, this has been a long, and there were many programmes before this that attempted to do what we're doing now, but we have really difficult to get access to government data. Within the civil service, it's difficult to get access to government data as well, but we're helping resolve those problems, not just for academics, but for civil servants as well. And we can fund government departments and organisations to work with us. So the ask isn't, can you prioritise resource to work with us instead of, I don't know, fund a prison service. That's not the balance that we're asking organisations to do. We will fund them if they will work with us to open up access to data. And because we've got the Digital Economy Act, that's actually been really, really powerful because it's one legal gateway that we can talk to I alluded to some programmes before ADI UK that had tried and sort of not quite got there in tackling these difficult problems. One of the case studies that really proved the value of what you can do when you link health and administrative data came from Wales, and really alcohol-related deaths in Scotland. And they introduced a policy, and then they asked our partners in Scotland to evaluate the success of that policy, and they were able to demonstrate that it did lead to direct reduction on alcohol-related deaths. And it was that evidence that gave the Scottish Government the comfort it needed to continue with that policy, and it's been looked at in various countries around the world now. one of the data sets I feel most proud about, because it's ADR England data set and it's been really, really difficult to deliver, is linking decades worth of education outcomes data with decades worth of health outcomes data. And there's a whole series of research questions you can answer using this, and researchers can apply to access this. It's free to access. This is through the ONS Secure Research Service, based just next door in Newport. And it's a fantastic data set. And the early research that's done, there's about 50 approved projects using this now. But one of the earliest research projects that was done looked at different education outcomes at age 7 and 11 by gestational age of the child. And I was always told, as you know, when I was pregnant with my children, that if your child is born between 37 weeks and 42 weeks, there's no difference for outcomes of your child. Well, it turns out actually there is. If you look at it at the scale that they're able to look at it from eChild, so you'll see the black bars, they're education outcomes at age 7. And there's a significant difference between education outcomes of children born at term versus ones born at 37 weeks. That does reduce down the blue bars by age 11. But we now know this, and educationalists can do something about it to help those children born at earlier gestational age to be able to catch up with their peers. And anyone from the cancer research world will know that it's a really big thing, understanding the impacts on different family members when a child or an adult has a health condition. Well, this is now possible within eChild as well. So you can look at, you know, the impact on siblings of a child having a significant health condition and the impact on their education outcomes as well, which is incredibly valuable because there's a heck of a lot of evidence to support that this is a big thing, but we've never been able to look at it at a population level before, and we can now. I just want to talk about the Ministry of Justice Data First programme as well. So this department has gone in the last sort of 7 years from zero to hero, I would describe it as. So they actually came to us and said, you know, we'd love to give academics access to our data. We don't even have good access to our data because what we've got is 50 different streams of administrative data coming into the department from all the different parts of the court services, so criminal courts, civil courts, family courts, probation services, prisons. There's no unique identifiers. We can't make sense of it, so how on earth can we give access to researchers for it? We funded them to work out the pipes, if you like, and work out how to link that data. As a byproduct of that work, they came up with a Splink algorithm, which they made available to download. It's been downloaded across the world over 12 million times now, and it allows fuzzy matching between data sets where you don't have a unique identifier, essentially. And it's really quick compared to other algorithms for doing this. And yeah, they did what they set out to. All of these linkable data sets have been made available to researchers, and they're now also sharing that data with the Sale Data Bank in Wales because they want it to be able to link to things like census data, so you've got really good demographic information on people, and also health data, most importantly. And if you want to find out about public engagement we did around this, there's a really fantastic podcast episode with Amy Summerfield from Ministry of Justice being interviewed with David Maguire from the Prison Reform Trust about how we embedded that public engagement through civil society organisations into that programme. And it's a fantastic episode to listen to. And if I just give you a sense of where they've got to now, so they can now track people through different parts of the service, which all of these things were separate before and you couldn't tell you know, which groups were in which. Now, clearly John is a fictitious person, but I'm just going to tell you about the types of journey that you can map now. So if you think about this person, John, entering the family court as a child and being taken into care, and then later on in his childhood, he commits a crime. His case is heard in the magistrate's court. It turns out it's quite a serious crime, so he ends up in the Crown Court. He's taken to prison, and then he appears in the prisons data set. And then within 8 weeks, he has an assessment, and he's found to have multiple complex needs related to mental health and substance misuse. This is the first time that Ministry of Justice will know this person has complex health needs. And after completing half his sentence, he's released on licence, he ends up defaulting on his rent, and the whole cycle starts again. And this is a story of, unfortunately, a lot of people who end up in the prison system, and it starts there, back there, with the child being taken into care. And bearing in mind, most children don't get taken into care because of anything they've done. This is adults around them. This is the cycle that Ministry of Justice wants to break. And they've been asking to link mental health data to their justice data for at least 4 years. They haven't got anywhere. Hopefully that's going to unblock. But this is like the missed use of data, what we're not, the types of research and insights that we're not allowing if we don't try and, as a country, if we don't try and fix these problems. So there was a House of Commons Justice Committee report a couple of years ago that looked into the impacts of mental health on prisoners. And it estimated, it's got this fantastic quote that Ministry of Justice don't know the extent of mental health care in prisons. And you can see why, because they only find out about it kind of retrospectively. And Kate Davis, Director of Health and Justice at NHS England, estimated that 70% of our men and women at any one time will have a need around mental health. That is absolutely massive. And if we look at that compared to Scandinavian countries, if 70% is at any one time as a kind of minimum level, in Norway, Denmark and Sweden, their rates of people coming into prison with a mental health condition don't really get above 40. So it really, as a society, you've got to ask questions about who are the people who are ending up in prison and what support isn't being given to them before then that means they then go on and have this terrible thing happen to them in their life. Just want to talk now about missed use of research a little bit more. So findings from the National Evaluation of Liaison and Diversion Services in England. This was a report that was commissioned by NHS England, and they commissioned RAND to complete it. It ended up taking RAND 4 years to do this evaluation. Liaison and diversion services are basically looking at, potentially vulnerable groups and how you can support them so they don't end up with the worst outcomes in justice systems. So exactly what we've been talking about, basically. It took them 4 years to complete the evaluation, and even then they couldn't get hold of all of the data from NHS England that they wanted, so it had to be a bit of a fudge. 4 years and a lot of pain, and they swore they'd never do it again. Now, hold that thought. On this side of the screen, this is a picture of an asbestos mill near where I grew up in West Yorkshire in Hebden Bridge. And I remember this run as a mill, and my mum was a GP, and she was part of the group of people who were working for years to try and prove the link between asbestos exposure and mesothelioma, which is a really, really nasty cancer, which you will have a horrible death from, essentially. And I was interested, could we solve this problem earlier now rather than when they were trying to do it in the 1980s? Hold that thought. So now we've got the Cancer Research UK CD3 programme, which is a £10 million programme, which ADI UK are a proud supporter of. And it's going to link up, it's going to do a whole load of things. Ashley's involved. If you want to understand the details, then please do ask him. But essentially, it's the reason why we were really interested in getting involved is they are thinking, well, you know, we've got so much more data available to researchers. Instead of thinking about cancer in terms of genetics, you know, can we think about it in the context of the person and all of the other social factors in their lives that mean some people might be more likely to get certain cancer or die of a certain cancer. And I said, absolutely yes, please go and talk to the SAIL data bank because they've got access to all this cancer data and they could really help you to do some great stuff here. So as a kind of pilot project to demonstrate what could be done, SAIL researchers looked at, and because Wales is a country of 3.1 million people, so we could only look at the most prevalent cancers and really drill down into details with a whole load of demographic information. But we proved that it was possible to do this and that it came out with some really good insights. So in screening programs, people who are less likely to take part are people from deprived areas, younger individuals, people from certain ethnic groups, people who are single or solo living individuals, and people who have existing health conditions apart from cancer diagnosis. Now, if you know this and you run your screening programme, then you can start to target certain groups in society so that they don't end up being the ones with the higher mortality rates from certain cancers. So this was enough to convince CRUK and CD3 that this was worth investigating further. Because if you think that that's a typo, that should be 3.1 million for Wales. If you think about that size of the population, and the population of England is £57 million, at the moment we've done breast and bowel cancer, you know, and just scratch a surface on what's possible within the SAIL data bank. If we could do this for English data, then think what other deep insights we could get to if we could link cancer incidence and screening data with a whole load of administrative data sets as well. And retrospectively, could we have evaluated the risk of asbestos exposure faster? I did a little bit of research on this, you know, very quickly, and I hadn't appreciated that, you know, it was quite some years ago that the link between asbestos exposure and cancer were sort of suggested, and that was really sort of, this paper in 1935 was the first one that properly suggesting this link between mesothelioma and occupational asbestos exposure. It took another 70 odd years until it was actually banned, and this is a time, it was the early 80s that my mum and various lawyers and other people were trying to sort of prove the link in the court so that the families impacted on it could get compensation, many of whom died before they got that. But yeah, could we do it faster these days? Are we facilitating that kind of research that you can do this kind of evaluation quite quickly? I'm not sure actually, but I think we probably should, and we should have things set up prospectively so that we can look at these things when a risk is identified. But yeah, looking forward, we've got refunded for another 5 years going up to March 2031, so 168 million. It's a heck of a lot of things we're going to do with that funding, but it basically means more data linkage, more training capacity building. We've got PhD cohorts existing. In this investment period, that's going to get bigger. And yeah, more funding for impactful research and insights that improve lives. And this was all based on an interim evaluation of our programme, external one, that we did last year, commissioned last year, that said that very conservatively, for every £1 spent on ADI UK, there's returns of over £5 of benefit. And I think that's really, really important, because at the time in this investment period where we were making such a big thing about things like public engagement, people were looking at that and saying, but isn't that an expensive, nice to have? And absolutely not, because if we didn't have that, we wouldn't be able to demonstrate those benefits, because we wouldn't have been able to unlock so much data. Thank you.
Questions in the end?
Yeah.
That will be moderated. Thank you so much.
Everybody is looking for better healthcare solutions. What if AI could be the answer? AI in healthcare isn't just a buzzword, it's revolutionizing patient care. With AI, we can achieve more accurate diagnoses and personalized treatments tailored specifically to each patient. AI systems analyze vast amounts of medical data at lightning speed, identifying patterns that might be missed by human eyes. This means early detection of diseases, fewer errors, and more effective treatments. But the magic doesn't stop there. AI helps streamline administrative tasks, giving healthcare professionals more time to focus on what they do best, caring for patients. The result? Enhanced patient outcomes and improved quality of life. So whether it's predicting patient needs or making real-time decisions, AI is transforming healthcare, one patient at a time. Embrace the future with AI-driven healthcare solutions. Because better health outcomes start with better technology. Ready to take the leap? AI in healthcare. Better diagnoses and treatments. Making healthcare smarter, one innovation at a time.